Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Elsevier, an ongoing exploration about how to improve health and healthcare. It's an unfortunate reality that there are significant differences in life expectancy in the United States based on where you live. A study released last year, in fact, by the Yale University School of Public Health underscored that fact by revealing that life expectancy gains in many southern states have lagged behind the rest of the country due to persistent disparities tied to access to care, economic conditions, and long-standing structural inequities. Dismantling those inequities and amplifying community voices is the focus of our guest today, Robyn Bussey, the Just Health Director at the Partnership for Southern Equity. In that role, she leads initiatives designed to help communities, organizations, and institutions understand and operationalize health and racial equity. Previously, she served as community health strategist with the Atlanta Regional Collaborative for Health Improvement and as a senior research associate at the Georgia Health Policy Center at Georgia State University. Well, thanks so much for joining us today.
Thank you for having me. Glad to be here.
We always start by asking our guests about their backgrounds and their career journeys, and in your case, that spans biology, business, and healthcare management. So I'm curious what set you down that path that led to your equity work, and what are some of the highlights along the way you'd like to share with us?
Yes, it's a very circuitous journey, and one I know my dad wishes was a little bit less circuitous and more straightforward. But it actually began because I wanted to be a physician, or so I thought. Very dedicated to that. I really want to, work with folks, and I really want to make sure people have good health. And I should back up a little bit. So that comes from my mother is a retired public health nurse practitioner. So I've been in and around public health and just kind of, community health, working with folks all of my life. My dad is a retired high school principal. So just working with different kinds of folks. And so just really always trying to understand why some folks had some things and some folks didn't, and, just not really understanding why that was. So in my mind, growing up in the 80s, I want to be a doctor. So why not? Till I got to college and majored in biology, and then organic chemistry came and showed me that maybe I didn't want to be a physician.
That stops a lot of people, organic
Yes.
chemistry, yeah.
Oh, yes. And yeah, not many things scare me, but organic chemistry remains an Achilles heel for me. But and so I finished, of course, in biology, and I knew I still wanted to work with folks in some way in health. Was advised by my mother, very wise, that I probably shouldn't be a nurse because I don't have the temperament or patience to be a nurse. So, trying to figure that out. So, like a lot of people after college, what do I do? Like my first real job was working actually at a janitorial company in accounting and IT. And so I said, okay, well, this is cool. So let me go to grad school for this. And I started, but, still just trying to figure things out. And there was a dual health administration, business administration track. So it's like, okay, at least, I'll still kind of be health adjacent. But, the business side wasn't really it. And not to date myself, but dating myself, I started my grad school work at Georgia State University. And so it was right before they started their public health school, which is now a few years old, it's probably a couple decades old. And I was like, okay, this is great. But by that time, I was really far along in my other studies, so I didn't change it. So I graduated, started to work for the State Department of Community Health in health planning and, around certificate of need, making sure folks could get what they need to build hospitals and capital projects like that. But again, it just didn't feel as community oriented for me as I really wanted to be. And so I found my way to the Georgia Health Policy Center, where I stayed for quite some time. And that really felt more like what I was supposed to be doing. So that was more, community health, public health embedded. And of course, just still really driven, by that foundational belief that everyone is entitled to good health care, good well-being, regardless of where they're from, their reading level, what they look like, all of these things. And so really just kind of found my way into health equity, which is what I was always doing and probably pulled toward, but didn't have the language for when I was doing all of my work. So yeah, so that's where I really just kind of got a name for the work that I was doing and wanted to do, and really, focused a lot on health equity and particularly the social drivers. And, after, of course, doing more research and understanding that structural racism is a driver of health. So that kind of led me to where I am now as just health director at Partnership for Southern Equity. So as you see, not a straight line,
Yeah,
but I got there eventually.
there are very few guests that have the straight line, so you're in
I
good
appreciate
company.
it.
Before we learn more about the Partnership for Southern Equity and Just Health, there was so much talk about health equity and structural racism and diversity issues in our healthcare system around COVID. It was like a lot of people discovered all of a sudden that this was a problem.
Yeah.
And there was so much energy and so much talk about it and talk about policy changes and stuff. I wonder if you could just tell us, what happened from all of that in your view, and did it help in some way, and at least it broadened awareness if, the actions haven't followed in the way you'd like to see?
So yeah, so COVID definitely woke a lot of people and organizations and institutions up to health equity and just kind of racial equity, social equity in general. And, for those of us who've been working in that space before, it was like, okay, well, welcome. We've
Yeah,
been here,
right.
so we're glad to have you, right? Have you and your resources and your energy. And it was a great time. It was not a great time for everyone. Of course, we were in a global pandemic, but it was just a great time to really have that focus and that energy. But, as things do, if you're not actually committed, or if it's something, new to you, the next shiny thing kind of pulls you away. And so as we, air quotes, got COVID under control, and I can't say we started to move to this post diversity society as a whole, but as administrations change, that tends to happen. But a lot of it was unfortunately performative on the part of a lot of institutions and organizations. And so, if it's not embedded in your culture and it's not something that you're actually committed to, then, when the tide shift, then you shift along with it. And I think that's really what has happened in the diversity, equity, and inclusion space, in health equity. Certainly, there are some organizations that are very committed to it and they're still trying to do the work. But of course, it's gotten much more difficult. But we definitely don't see the commitment and the interest at the levels that we did. I'll say, 2021, 2022 was probably at the height. But yeah, if it's just kind of something that you're doing because everybody else is, or that's, what's the tide or the trend right now, then, sure. But, when those grants end or that time ends, then it kind of goes away. So that's what we're seeing right now. That wind has shifted. And unfortunately, a lot of people who came late to the party also left.
Hmm.
So, and there are folks, and I have a little bit of hope too, that we're getting to a point where it's about to change again. I think people are seeing what our society looks like post that period. So I'm hoping that people will start to pay more attention eventually. I hope that it does not come with another global pandemic. We don't need that.
Right.
But yeah, I think that's exactly what happened. But one thing that I appreciated about it was that it showed us that we can do this work. We can do this. We can, shift resources in a way that help disadvantaged communities and, really reach out and communicate with them and bring them into the fold and help them have what they need to thrive and survive. So it's not a matter of we just can't do this or we don't have the resources to do this. It's definitely the will to do it. So I'm hoping, again, barring another COVID or COVID-like experience, that we'll get back there and it'll be more meaningful this time for sure.
Yeah. That's a hard way to learn,
Yeah, for sure.
The other thing, just as long as we're talking about what's rooted and not rooted,
Mhm.
before COVID, there was this whole population health movement. Actually, I think kind of grew out of Obamacare.
Mhm.
But the whole concept of social determinants was being talked about in ways that it hadn't before.
Yes.
I'm wondering, in the same way I asked you about the racial inequities in healthcare, do you think that understanding has penetrated and is sort of lasting in a different way.
I think so, more so than kind of the general diversity, equity, and inclusion movement. I think people are using that language, and certainly in my space, and I have to admit that I'm in a bubble sometimes, but definitely in my space, people are definitely having those conversations from the social determinants of health perspective. And even now, we're trying to move past determinants to drivers and influencers and, vital conditions and things like that. But I believe people are starting to make the connection between so-called like non-health issues and health and well-being. So, for example, housing, affordable housing, education, income and employment. So I do see that sticking around. Now, what I don't see as much, and again, I think this is a byproduct of us shifting from that mega health equity movement, is structural racism being named as a driver, which it very much is, but it's probably easier for people to grasp the other issues, again, like housing and education, because, it's probably easier to talk about.
Mm.
But in general, I do see folks, kind of clinging to that knowledge and really working from that standpoint as far as health equity is concerned, that we have to consider those drivers, those social drivers of health for sure.
Yeah, thanks for indulging me there. It's very interesting. So, about the Partnership for Southern Equity, why don't you fill us in on that and also the Just Health program that you run?
Absolutely. So, Partnership for Southern Equity, or PSE, we are based in Atlanta, Georgia, and we are a nonprofit that focuses on advancing policies and institutional actions to advance racial equity and shared prosperity for all. And we say in the American South, but eventually we hope to expand to the global South. I know our executive director, Nathaniel Smith, would be glad I said that, because we understand that the issues are really the same at their base in the South. And, in terms of racial equity, as the South goes, the nation goes. So we focus on that work, but we do it through our kind of ecosystem model, realizing that people don't live single issue lives. So we focus on energy. So we have every portfolio has just. So we have just energy, focuses on energy and climate. Just growth, that focuses on equitable growth and development. Just opportunity focuses on equitable workforce and economic inclusion. We have just youth, which is our youth power building arm. So really growing that next generation of leaders, and they work throughout all of our portfolios. And then, of course, my favorite, Just Health, which is the health equity portfolio. It was established 2019, so a little bit pre-COVID, working in rural Georgia. So if you know anything about Georgia, there is the metro Atlanta area, which depending on the day and who you talk to, could be anywhere from 13 to 33 counties. And then, Georgia itself has 159 counties. So all the other
Yeah.
ones are not metro Atlanta. Most of them are rural, and particularly in the South, the southernmost parts of the state, and the northernmost parts of the state. So Just Health was built on really working in those communities to kind of grow health coalitions to address those specific concerns that are very different for rural Georgia than they are for metro Atlanta. And kind of being the racial equity consultant. Because as you might imagine, having conversations around race and racism in those communities are not always easy. But, we were
Mm.
able to do that. So that's really how Just Health got started. And I joined PSD in 2021. So at the height of COVID, when everything was really, people were handing out grants and please work with us. And so, we really focused again on getting information out around vaccines and really increasing vaccination uptake. But as we started to kind of grow as a portfolio, we really had to think about what we're going to focus on, because, anything health was coming our way. And health, I love health and I can tie anything to health, but we can't do all things in health. Sort of narrowed our focus, and we have three priority areas now, which are still broad, but it was really where we focus. So that's climate change and health equity, that intersection, and of course, environmental justice components of that. And then access to health and social services, because we are in Georgia, and unless something changes, we are not expanding Medicaid. So, how do folks still get access to the healthcare and social services they need in light of that? And of course, the unique issues that are in our rural communities. And then my kind of passion area, which is reproductive justice, but with a real focus on maternal health. Those are our major focus areas. And we do work in a number of ways. We do a lot of training and technical assistance for communities and organizations, governments, anyone who's really interested in understanding more about health equity and how they can embed, the principles of health equity into their work. And then we do a lot of capacity building for community members. So, really growing their capacity to advocate for themselves where health equity is concerned. So, we do, translate research for communities, work with them to understand issues, in particular, like our climate work. A lot of that is understanding that intersection, like kind of taking the climate conversation from I always say polar bears and ice caps to, like my energy bill is really high. Why is this happening? And or even why do I have these terrible headaches, when it's really hot? So getting folks to kind of understand the real world implications of climate and health. And yeah, we do the trainings. We, get folks to name issues, advocate for those issues. Like, how do you contact your local elected official? Where can you plug in? Understanding policies that may impact them, that they may advocate for or against. So that's really how we do our work. And we partner with lots of wonderful folks who are also doing similar work, in particular for maternal health. We are not the experts. There are a lot of folks doing great work. So, however, we can partner with them to bring our talents to the work is what we do. So, that is just health in a nutshell, a really
Yeah.
broad nutshell.
Got no work at all to worry
No,
about
no,
there,
no, plenty of time.
Wow, that is quite the list of things to be working on at the same time.
Yeah.
I want to get into some of the actual on the ground stuff that you're doing. You mentioned building health coalitions, but I want to back up a little bit. So, aside from structural racism, what are the other primary structural barriers to health equity that you see?
Yeah, I mean, in my community, I'm in the Metro Atlanta area, South Fulton County, so like very near. I always tell people, if you've ever flown into Atlanta, you've flown into my city. And Fulton County, I think, is probably a really great example of, what we see kind of nationally. We always say it's a tale of two cities, but it's really counties. There's a highway that really kind of divides the county in half, more or less. And north of the interstate, I-20, you see better health outcomes, better social outcomes. It's kind of a more affluent area. And then south is really where you see, a whole host of issues. And so in that setting, we see so many structural issues, income inequality, which we probably hear about in Atlanta all the time and so many other cities, is really huge. Access to good food. There's food, we don't even say desert, there's swamps, there's food. Like if you want any type of fast food, you can find it. But if you really want to be able to get affordable, healthy food, it's really difficult in some of these communities. We see differences in education. Our public schools are less well funded and supported. In this particular community, employment opportunities are drying up in the community. So all of those things that, again, that might not necessarily on its face have like a health component or intersection very much influences the health of folks in this community. So we see a lot of that. And not to say there aren't bright spots, because there are, but those are like those really kind of broad structural issues. And housing. Housing is huge. Affordable housing, of course, is a national issue, but you can really see it in our communities. Folks are being driven out of their homes, or the homes, they're having a hard time maintaining them. So yeah, it's all of those things. It's really a convergence of those things in several of the communities that I work in. The one I live in, as a matter of fact. Yeah.
So, getting to the on the ground piece of this, you emphasize centering community voice in this work. What does that mean exactly, and how do you go about doing that?
Yeah. So, and we struggle because there's so many words and so many ways to define community. But in the sense of really working with the folks who are closest to the issue, who are most impacted by the issue, it's really seeking out and earning the trust and respect of those folks. Building relationship is really huge. And then once you're able to do that and earn that trust, work with them to really be front and center. So it's one thing for someone coming from, as I used to be affiliated with the academic institution, coming in and saying, we think you should do this. So we looked at the data, we looked at the maps, and we see that there's need. And we feel like based on what we see, the evidence-based strategies, because we love those, you should do X, Y, Z. That's good, but you really need someone who's in the community, who's impacted by these issues every day to say, okay, actually, this is what's happening.
Mm.
These are the stories that I have to share, or this is my experience. And based on that, these are the things that I believe will work, or I know will work, or are working in my community. So really finding those folks who are what we call community champions, who are embedded in the community. They may not have an organizational affiliation, they may. But they're the ones telling the story. They're fact checking, or really saying, let's look beyond the numbers, let's look beyond the maps. And they can also raise the good points. So there may be like, someone passing out food to children after school, a program. It's not even a program, it's just something someone does, but it works, and something that, is really able to sustain and support folks in community. Lifting up those stories, having those folks be front and center and saying, this is what we need, this is what we have. And, this is what will make our lives 1,000 times better. And in turn, improve our health outcomes. So really centering folks who are there doing the work, affected by the work, who can drive the work, and sharing power is what it looks like a lot of times as well. Again, coming in with all our data and maps. I love a good map, but having folks who can really ground truth it and say, okay, yes, this might be happening here, but what about this? And so, you go in and a lot of people like to do community gardens, and it's no shade to community gardens, but most communities don't actually need a community garden. They might need a community co-op. They might need a clinic. It might be a whole host of things. So really asking folks and checking with folks about what they need and letting them determine what their best route for success and better health. So yeah, that's what I always think of when I think about centering community. It's just moving out of the way and letting community lead, for sure.
Yeah, and building trust that you are listening, and
Yes,
that you're a partner with them. You're not sort of trying to dictate things.
absolutely. Because we've seen so many times in a lot of the same communities where, again, someone saw a map or some numbers and they came in with this brilliant idea and they wanted to get information or extract basically from community, and either they take it for whatever, nothing happens. There's a lovely report that goes to someone that no one in the community ever sees,
Mm.
and nothing changes. So that trust is really critical that, yes, we're sharing this data. This is your data. We're sharing the information. We're, working with you on this. So I always lead with the mantra, do nothing for us without us. So that's really the grounding in the work. You don't go and dictate, you go and listen and trust and be a partner, like you said.
So what's working? I mean, are there some strategies that you see, or is it just so individual to particular communities that it's not something that you can scale? But where are some bright spots in this, if any?
Yeah, I mean, yes. For me, I'm really kind of closer, I would say, to the ground. So I see, some good things there. I'm all about community health workers. I think community health workers are amazing, and I think that model is amazing and can be in community. Here in Georgia, we are still working on certification and reimbursement for our community health workers, but that model to me is amazing because there's, kind of a workforce element to it as well. Folks who may not have ever considered maybe working in the medical field, and not saying that they are, but they're not physicians, but they can work with our physicians, our clinical folks. They make connections to better housing, to, employment opportunities. And sometimes they're just there to listen. And people need that so much because social isolation is huge in our communities as well. So I see that working wherever, we can deploy community health workers. And we recently wrapped up a project in my own city where we had a community health worker dedicated to working here. She stood up a community-based health equity coalition And, they were able to just do great work. It always kind of goes back to feeding people, but feeding people, bringing people in to have the conversation about what good health would look like in our city. And there have been several health initiatives that have come out of that. From the public health department standpoint, them having community health workers is amazing. Some of our safety net hospitals work with new mothers, which I think is great as well. So there's some things that are working. Now folks are really on fire about data centers, as you can imagine. That's probably on everyone's radar right now. But really, folks coming together around those and understanding what the health implications are of data centers and the health and environmental implications. And, folks is really getting involved, just really seeing communities get an issue and really get their education around it and just kind of take off and start to advocate for themselves. So I see that a lot. Policies to try to expand access to care, advocating for standalone emergency rooms or new hospitals even sometimes. And people talking about, because we've had a lot of hospital closures in recent years here and throughout the state, and folks, saying this is not working for us. So what can we do to do better? So yeah, a lot of food security initiatives. So there are things that are happening. And I think if we were kind of back in that COVID heyday, we still had all those resources, I think we would see those things scale a little bit more.
Yeah. Well, let's hope the pendulum swings again.
Yeah.
So, as you know, we have a lot of students and early career health professionals in our audience. I'm wondering what your advice to them is about what can they do, either as students, but then when they get out on the job as clinicians, to advance this work. What do you need people to do who are in those positions?
Well, the first thing, please don't give up. Don't leave the field. We need you. We desperately need you. Particularly our public health workforce. We need you more than ever. Don't get tripped up on organic chemistry. Yeah, don't do that. But yeah, first understand that health equity is a part of your work and that it is both a way and a what. It's something we get to, but we practice. It's not something, that we do it and it's there, but it's also a process. And really, embedding that in your work, being open to learn more about what that is and what that looks like. And particularly for clinicians, working with communities, whatever those communities are, learn your community, listen to your patients, because we're still in an environment where a lot of folks still believe that the physician is the authority. So whatever the physician says, despite what you might be feeling or what you might be seeing going on in your own body, your own life, if the physician says something different, then you're like, okay, whatever they say. But you know that there's something wrong. So, listening to your patients and being partners with your patients, I think is really, really huge. Building that kind of culturally aware workforce is critical. Be willing to go places that you might not think are so appealing, like, a little town in South Georgia that might, have one stoplight, but they really, really need a physician. Just to kind of think about, changing your perspective and thinking about places that and people that you can support. But most importantly, and this is kind of where it gets squishy, but you have to really go in with an open heart and an open mind and really want to be partners with the folks that you're caring for and understand they're entrusting you with your care and build that relationship and listen, even if you don't have a whole bunch of time. And hang in there. Like I said, we need a strong clinical workforce at this time for sure.
Absolutely. Well, there's a lot of great advice for folks to think about there and try to work into their perspective as they enter their healthcare careers. I'm afraid to say we have to leave it there, but I want to thank you so much for being with us today.
Thank you. Thank you. I appreciate it.
And we wish you all the best in your really important work that you're doing.
Thank you so much.
I'm Michael Carrese. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisetheline podcast.